Dr. Michael Kohler, and this is Thad, who works for Loyola as one of our standardized patients. The purpose of this training video is to introduce first-year medical students to taking blood pressure and assessing pulse, and also introducing you to the steps of the cardiovascular examination, as well as reviewing some surface anatomy relevant to the cardiovascular examination. And of course, before we begin any exam, we always wash our hands, so I'm first going to wash my hands. Let's first review the 4 factors that influence arterial blood pressure. First, there's left ventricular stroke volume. Second, there's this distensibility of the large vessels and the aorta. Third, there's peripheral vascular resistance. And finally, fourth, blood volume. A change in any one of those 4 factors will influence the arterial blood pressure, whether it's systolic or diastolic. When assessing pulse, we normally use the radial pulse at the level of the wrist. It's superficial to the radial bone and lateral to the flexor tendons, which can be identified if you have the patient flex their wrist. By placing, again, the pads of your fingers just lateral to the flexor tendons, you can palpate the radial pulse. By simply counting the pulse for 15 seconds and multiplying by 4, you get the beats per minute. If you're unable to assess pulse at the radial level, you can also assess the pulse in the antecubital fossa by assessing the brachial artery. If you ask the patient to make a muscle, you can identify the biceps tendon, and then when they relax, just put your fingers, pads, medial to the biceps tendon, and you can identify the brachial artery and take the pulse there. Finally, you can also assess pulse by assessing the carotid artery in the lower third to lower half of the neck by simply placing your finger pads just medial to the sternocleidomastoid muscle. You'll note when you take the pulse, the symmetry of the pulse. When you're assessing radial artery pulse between the right and the left side, there should be a symmetry and you should feel both pulses simultaneously. You'll also, again, note the rate, what's the beats per minute, and you'll note the rhythm. You'll try to determine if the rhythm is regular or if the rhythm is irregular. If the rhythm is irregular, you'll try to determine if there's any pattern to the irregularity. Is it sporadic, or is it totally irregular? And by that I mean, is every third beat come early? Is there a pattern? Or is there a pattern that the irregularity varies with respiration? Does the pulse speed up with inspiration and slow down with expiration? Or finally, is there no pattern whatsoever, in which case the pulse would be irregular, and that's always an indication of atrial fibrillation. If the pulse is irregular, you need more than 15 seconds timing to assess the pulse. In fact, if you're not sure, you may need to check the pulse for a full 2 minutes. You, of course, need a sphygmomanometer with a blood pressure cuff. And of course, a blood pressure cuff is not one size fits all. The largest blood pressure cuff is known as a thigh cuff, although this can be used on a patient who has a very large arm. The width of this cuff is approximately 18 centimeters. The next largest cuff is known as a large adult blood pressure cuff, and this one is approximately 15 centimeters wide. Then we have the normal adult blood pressure cuff, and it is about 12 or 13 centimeters wide. And finally, we have the smallest blood pressure cuff, which can be known as a pediatric or small adult cuff, and this one is about 10 centimeters wide. To determine which cuff is appropriate, we need to measure 2 different variables on the arm. We measure the width of the blood pressure cuff against the patient's arm. The width of the blood pressure cuff should be approximately 40% of the circumference of the arm. Also, determining the total length of the bladder of the blood pressure cuff, which is where the tubes come out of the blood pressure cuff. When you wrap the blood pressure cuff around the patient's arm, it should approximately be at least 80% of the circumference of the arm. The length of the bladder does not represent the entire length of the blood pressure cuff. Notice where the tubes come out of the blood pressure cuff, and notice that that area is thicker. This is where the bladder of the blood pressure cuff is, and it's the length of the bladder that we're interested in, that should be 80% of the circumference of the arm to be the correct size. So a normal adult cuff fits that just fine. Go ahead and place the blood pressure cuff snugly on his arm. You'll notice I'm approximately 2.5 centimeters above the antecubital fossa. Bates will recommend that you check the blood pressure with the bell of your stethoscope, but I think you'll find most physicians at Loyola use a diaphragm to measure blood pressure. Again, the blood pressure must be taken on skin. It shouldn't be taken over an article of clothing or the patient's gown. The patient should be relaxed and calm. Don't check the blood pressure. The patient just rushed into your office, they're late, or if they're crying, because of course the blood pressure will be elevated. First, we're going to check the blood pressure by palpation. Simply identify the radial pulse, tighten up the valve in the blood pressure cuff, and by watching the sphygmomanometer, I'm going to determine when I stop feeling the radial pulse and blow up the cuff approximately 20 beyond that. And I felt the pulse disappear about 110. As I released the air from the cuff, I felt it return about 110. This tells me that the systolic blood pressure is approximately 110. So when I go to auscultate the blood pressure, I know I only need to auscultate above about 20 millimeters of mercury, approximately 110. I don't need to blow the cuff all the way up to 200 and to hurt his arm. You notice that the brachial artery should be about at the level of the heart, but the patient's arm should also be relaxed, so you as the doctor should be the one holding the arm up. Don't ask the patient to hold their arm up, because that again can falsely elevate their blood pressure. So close the cuff and the valve, and then slowly blow it up again, about 20 points again beyond where I felt the blood pressure disappear by palpation. I'm going to slowly release the air. The point at which I first heard the blood pressure pulse return was 116. I heard the pulse disappear at approximately 76. So the blood pressure by auscultation is 116 over 76. And of course, I'm going to repeat this in the other arm, both by palpation and also by auscultation. And again, it's important to use a right-sized cuff, because if the cuff is too small, it'll falsely elevate the patient's blood pressure, and you may diagnose the patient with high blood pressure, hypertension, incorrectly. So let's finish up with blood pressure by reviewing some of the common errors in assessing blood pressure. First, again, checking the auscultation over an article of clothing or a gown is incorrect. Using a cuff that's too small will falsely elevate blood pressure. 3, not elevating the arm or the brachial artery to the level of the heart would cause an error. 4th, if the patient just held their arm up themselves, they'd be contracting their muscles, and that would falsely elevate blood pressure. So again, you as a physician needs to help elevate their arm to heart level. And also, if the cuff is too low on the arm, you'll occlude the brachial artery and be difficult to hear it. Next, if the patient's not relaxed, if they're upset or crying. And then if you deflate the air from the blood pressure cuff too quickly, the air will move down so fast you won't be adequately able to tell when the diastolic and systolic blood pressure actually are at. Now that we've completed blood pressure, let's review some key surface anatomy that's relevant to the heart exam. And Thad, if you could lower your gown for us. As you remember from the thorax video, there's a few key vertical lines that are important. First, there's the mid-sternal line, then the mid-clavicular line, and of course we use the clavicles to help us identify the mid-clavicular line, and the anterior axillary line. Also important is the sternal angle, or the angle of Louis, which is the bony ridge in the manubrium of the sternum, because just lateral to that is the second rib. And we use that to count ribs inferiorly to locate things on the chest wall. And then the costal angle is found in between the costal margins anteriorly, and the epigastrium is in this area. So why do we examine neck veins? Measuring neck veins lets us estimate what the patient's right atrial pressure is, and that helps us to assess what their patient's volume status or hydration status is. To get an exact measurement of the patient's volume status or hydration status, we need to do an invasive procedure which involves risks to the patient as an expensive. So instead we just use the height of maximum pulsation of the internal jugular vein to assess for this. If you look closely at the neck vein, you'll notice that there is a pattern of 2 waves and 2 descents per heartbeat. The A wave comes just before S1 and is the highest pulsation, and that represents atrial contraction. The X descent follows the A wave. Next comes the V wave, which is right before S2, and this represents atrial filling. This is followed by the Y descent. You may need to listen to the heart with your stethoscope while you watch the neck veins. The A wave comes just before S1, and the V wave coincides almost precisely with S2. Or you may need to palpate the left carotid artery while you're watching the right internal jugular vein to identify the timing. Remember that there's only 1 pulse per beat from the carotid artery, whereas there's 2 venous pulsations per beat, the A and V waves, from the internal jugular vein. Let's talk about examining the neck veins. This is not an easy examination step to learn. The position of the patient is important. Bates says to have the head of the table elevated to 30 degrees, and the Loyola 65-step physical recommends 45 degrees. If you have difficulty assessing the neck veins, you may need to raise or lower the head of the bed to help find the neck veins. The patient's head should be turned slightly to the left, and the physician should be on the patient's right side in the classic examination position. Again, the area we're going to be looking at is just above the clavicle at the base of the neck, near the sternocleidomastoid insertion into the clavicle. First, let's again identify the external jugular vein by pressing just deep or beyond the clavicle. Again, we can see the external jugular vein easily distended with this maneuver. But again, that's not what we're interested in. The internal jugular vein pulsation doesn't appear as a vein or as a column of blood. Instead, we see the pulsations arise through the skin and subcutaneous tissue. What you notice is the skin is kind of lifted up in 2 pulsations per beat, sort of in that manner. Sometimes it helps to look tangentially or to use an indirect light source to increase the shadows to find the pulsations when you're first trying to do this. It's always better to use the right internal jugular vein because that's a more direct route or channel to the right atrium than the left internal jugular vein. Remember, what we're looking for is a point of maximum pulsation. Once you identify the point of maximum venous pulsation, you need at least 1 ruler and 1 other straight edge. Put 1 ruler in line with the point of maximum pulsation, then put the other ruler at the sternal angle and measure what the reading is on the ruler that's resting vertically on the sternal angle. Normally, that reading will be 1 to 3 centimeters or less. To estimate the right atrial pressure, always add 5 to your measurement. Again, this is a difficult technique to master and takes practice. So don't be too rough on yourself if you have trouble identifying this initially.